Thank you very much. Thank you. Can I just say a big thank you to the organizing committee as well as especially to Lalit for inviting me for this meeting. It's already been a very fascinating discussion about various topics which are so important for us in our day-to-day practice. My topic, before I start my discussion about treat and extend, can I just say that I've had some experience, but my colleague in Sheffield, Fahad Kuhil, he's had plenty of experience with Iluvien. And for these intractable diabetic macular edemas which are not responding to anti-VEGFs, what we do is we try Ozurdex, and if there is a decent response with Ozurdex, then we go for Iluvien. But obviously cost is a factor, and apparently it's not available.
We don't have access to it.
Yeah. So I have no financial disclosures relevant to this topic. The heading of the topic does suggest that this is about the real world evidence, but I thought I'll make it slightly different in that I will discuss more about the protocol of treat and extend, and then at the end I'll mention some of the evidence which is present in randomized controlled trials as well as real world evidence. So before I start, can I just have a quick survey, show of hands? How many of you treat these conditions with anti-VEGF actively in day-to-day practice? So
All of us.
all of you. So this is a good audience to talk to in that respect. And which anti-VEGF is the treatment of choice at the moment? Lucentis, how many?
I think we'll have to ask specifically Avastin, how many people use? So you can have a show of hands.
Yeah.
Then Ranibizumab, how many people use? It's, I think, half and half, slightly more in favor of
And
Ranibizumab.
aflibercept,
Eylea.
Eylea, less.
Slightly less.
And is that
it's
cost-
because of
cost
cost?
is
Because the cost of
Sure.
aflibercept is double
Yeah.
here.
Yeah. And lastly, regarding the protocol, so is it like a loading dose and then pre-RN treatment that is more common, or?
Let's ask, because loading dose, I think everybody gives an ARMD.
Yeah.
But after that, for me, it is treat and extend. I think PRN, who does PRN after loading dose? I think the majority do treat and extend only.
Treat and extend
Yeah.
only, yeah.
Can we ask the show of hands? Because how many of you start with loading dose? Yeah,
How many of you don't do a loading dose at all? Maybe just one injection and then,
so only one.
and
Okay.
Dr. Anand there.
Yeah.
Yeah. Yeah. Okay, and this is about the assessment of how your treatment is working for you. So I would presume in most of you who are doing private practice would make the assessment on individual
OCT.
basis. But to those of you who work in institutions, maybe they have their own audit, or how would you assess that the treatment is working in majority of cases? So that was just a quick.
Apart from clinical imaging, like people do OCTs, and assessment is based on that in the initial
So
vision. Yeah, apart from
yeah,
clinical,
yeah.
I said.
So it was more in terms of how effective is the treatment, so the different criteria. So for some of you, parts of this talk may not be so relevant because I'm discussing what's happening in the United Kingdom, and but it depends. For example, if you have a patient of proliferative diabetic retinopathy, then obviously you can offer that patient anti-VEGF instead of PRP laser. But in UK, we don't have that facility because we can't use it as per the NICE guidelines. Similarly, what we do in the UK may not be so much relevant in your day-to-day practice, but it's still worthwhile knowing what's happening across the world. So we have a big problem in UK with these macular diseases which require anti-VEGF, and because it's a national health service, there are quite significant constraints to our resources and staff, and therefore we have to come up with these new protocols to try and maintain and even improve the management of the patient, but at the same time manage within our resources. So just to give you an example, we have around 40,000 new cases of wet macular degeneration per year in that country, and it's a small country. So that equates to around 300 to 400 intravitreal treatment per week per million patients, and therefore the treatment regimens and also injectors have evolved over the years to manage these conditions. And why I have put injectors is because I remember 10 years ago when we went to one of the Royal College of Ophthalmology meetings, somebody mentioned non-doctors giving injections, and there was a huge furore about it. But now even a premier hospital like Moorfields in London, they have around 15 nurse injectors who are doing the injections. The bulk of the treatment is actually being done by nurses. And even orthoptists and optometrists, they are now injecting these patients for AMD.
I don't think so. In India, this is the norm that nurses and they inject.
No, it won't be.
Yeah.
But what I'm saying is these things have happened because we just don't have the resources to manage the patients just by doctors alone. This is just a quick slide. We have what we call Medisoft, which is an electronic patient record. This is just a quick slide of 2 years of our center in Chesterfield, where you can see that the results of PRN treatment are not very comparable to the Anchor and Marina trials. So the average letter gain is considerably less, and you can see those spikes as well. So there are quite a few factors involved there. But generally, if you look at the real-world evidence for PRN treatment for neovascular AMD, the overall visual outcomes have been considerably less across the whole country compared to Anchor and Marina trials. So what are the disadvantages? And again, this is in context of the National Health Service that we have, is that because of various factors, the monthly visits may not be able to maintain. So the patient comes in 5 weeks or 6 weeks instead of every 4 weeks. The retreatment criteria, because the patient is being managed by different doctors, the retreatment criteria is subjective instead of objective. So sometimes the patient does not get the injections that the patient needs. And because of, again, resource constraints, the timing of injection may vary because of capacity issues and in two-step clinics. So, as I said, the real-world evidence of PRN treatment in UK has got poorer outcomes. In our unit, at the moment, we have Eylea as the first treatment, and that for neovascular AMD, and that is fixed dosing. So we give injection number 1, 2, 3 every month, and then we switch to every 2 monthly for injection number 4, 5, 6, 7. And that completes the first year of treatment, and the second year we switch to PRN. That was the protocol before we changed to treat and extend. So what happened was the retina outcome group, which is a retina specialist from across the country, they got together and they devised, they had a discussion about changing the protocol, and that's how the treat and extend treatment was started some years ago in the United Kingdom. And the main feature, for those of you who are not aware, some of you maybe, the treatment is continued monthly until there is no disease activity. The patient receives the treatment at each visit. The interval between the visits is extended if the criteria is met, and this is obviously in contrast to the PRN and the fixed dosing regimens. So this is an individualized treatment. The risk of delayed treatment in the presence of active disease is reduced, and it fulfills the need for uniform evaluation of disease activity. Now, there are various criteria, and I'll just go through it very quickly because I can see that I have very little time. The disease is considered active if there is new hemorrhage or intraretinal fluid or subretinal fluid, but after 3 injections, if any of these persist but is stable, then we consider that as a stable disease. I'll skip those. I have 10 minutes, Lilith, is it? Yeah. Yeah, so I'll skip those. And just to say that in some cases, again, we do switch from treat and extend to monitor and extend if they have been stable for a period of time. Obviously, 20% of the cases eventually turn to bilateral disease. So again, you have to decide what to do. And generally, we choose the eye which has a shorter course, and we go with that so that one eye may be getting over treatment, but it's better to maintain the visual acuity in both eyes. So in general, if you look at the studies, we found that the visual outcomes with treat and extend were quite favorably comparable to fixed monthly dosing. So in TREX, there was a gain of 8.7 letters versus 10 letters. In TREND, it was 8 versus 6. And in the Canadian study, also, it was non-inferior with fewer injections. And in all these cases, it was far superior to a PRN regimen. Also in a meta-analysis in 2016, the TNE was superior to PRN regime, and the letter gain was 8 letters versus 3 letters gain. And this is a Terra study was in about the real world outcomes in UK, and that has shown that the results are very favorably comparable to the monthly dosing. Nearly finished. So in conclusion, I think the treat and extend protocol for neovascular management has been comparable to randomized controlled trials and is significantly superior to visual outcomes from PRN treatment. And it is an individualized treatment. This is the main thing. You know, you don't overdose or underdose the patient. You give the patient treatment as and when they need it. And that would conclude my talk. Just one comment I would like to make, especially for current trainees, is that, you know, Britain has come out of European Union, and there has been several changes in the immigration protocols, which is happening already. In fact, one of the guys I've appointed as a consultant in my hospital is a trainee from All India Institute. So if any of you are interested in coming for training or for employment in UK, then please contact me. I'm happy to help you out. Thank you very much.
Thank you, Sanjay, for this nice talk. I'll request Dinesh to be prepared for the next. Meanwhile, any question, I think he'll be happy to answer. I think most of us practice this, that treat and extend, and never ARMD is a disease which should not be, I think, from beginning PRN. So, yes.
Yeah, hi, lovely talk, Sanjay. Just checking, your treat and extend, did you say that you bring them on a monthly basis if you're treating with Eylea, or?
Monitor, that was monitor.
Because it defeats the object.
So for the treat and extend,
Yeah.
we, after 3 months, we continue injecting monthly until the disease is stabilized. And then we inject on, say, for example, if you do 3 injections, one every month, and on the 4th visit, the disease has settled down, you inject on that day, but the next interval is 6 weeks instead of 4 weeks.
Okay.
And then if it is still stable, it goes to 8 weeks, and it goes up to a maximum of 12 weeks.
Right, because then you negate the benefit of using Eylea, because normally that tends to be 2 monthly. So it's fine for
the
Lucentis.
posology for both the drugs have changed now.
Right.
So with Eylea, you can go up to 4 months, 16 weeks
Sure.
between injections if they're stable.
Right.
And then obviously you have Brolucizumab coming, which is every 3 months. We're starting that in April this year. So again, that will change the equation, but at the moment, that's what it is.
Okay, thanks.
Okay, I think since time is less, we thank Sanjay for his excellent talk.